This presentation will provide a basic overview of lower limb prosthetics for support workers. We will discuss the definition of lower limb prostheses, the amputation pathway, prosthetic pathway, levels of amputation and prostheses, as well as provide an example of a support worker working with lower limb amputees. Prosthesis is an artificial limb substituted for a missing body part. A lower limb prosthesis refers to a prosthesis or device that replaces any part of the lower limb to restore the function and/or cosmetic purpose of the lower limb. This may include artificial components that replace the hip, thigh, knee, ankle, and foot. From the time an amputation occurs, there is a standard pathway that all amputees undertake as part of their prosthetic journey, which includes 7 key phases. These time frames will vary depending on the amputation, comorbidities, and adaptation to the prosthesis. Here is a basic overview of the 7 phases. For those that have a pre-planned amputation, i.e. an amputation that isn't part of a trauma, where surgery occurs almost immediately post-injury, there is the pre-amputation phase. This is where rehabilitation personnel help the individual prepare for surgery and post-surgical expectations. The amputation will occur, and then there is acute management and wound healing, usually provided by the nursing and hospital-based team. From there, the subacute or pre-prosthetic training phase occurs, and discussions about the type of prosthesis or assistive devices required will have occurred with a rehabilitation and strength training progressing. The 5th phase is the prosthetic training phase, where gait training for lower limb is progressed, with and without the prosthesis. In the advanced functional training, this may be where more advanced skills are retrained specific to the individual's job requirements, sporting ambitions, and other leisure activities. Finally, the ongoing plan is in regards to life moving forward beyond the rehabilitation phase. This will include regular reviews of their prosthesis, adaptation to new prostheses and technology, or more advanced training for newly acquired skills, for example. Depending on your clinic and service delivery, support workers may be involved with all phases. In relation to the specific prosthetic pathway, from the time that a prosthesis is prescribed, design of the prosthesis will undergo these 6 stages. Firstly, casting of the limb is then followed by a positive mold, i.e. the filling of the cast with plaster of Paris. Once this is solidified, rectification of the mold can begin. Assembling of the device then begin. Once completed, alignment on the individual will occur before the final cosmetic elements are completed. Support workers alongside prosthetic technicians may be involved with these various stages. There is a basic overview for each stage featured on physiopedia.com called Lower Limb Prosthetic Introduction that may be of interest to support workers. Levels of amputation for the lower limb are broken down into these 6 levels: partial foot, ankle disarticulation, transtibial, knee disarticulation, transfemoral, and hip disarticulation. The next few slides provide a basic overview of each level of amputation and the prostheses associated with these levels. Firstly, partial foot amputations. This figure from the Atlas of Amputations and Limb Deficiencies shows the 6 variations of partial foot amputations, ranging from toes and metatarsal amputations through to transmetatarsals and midtarsal amputations. Partial foot amputations are usually a result of diabetes or trauma. Depending on the extent of the amputation, the type of prosthesis prescribed may vary from a toe filler option, such as the image on the left, or one that requires componentry such as a prosthetic foot for the example of a transmetatarsal or Chopin amputation, i.e. the toes and forefoot have been amputated. The next amputation from partial foot is an ankle disarticulation or through ankle amputation. Ankle disarticulations are usually a result of trauma, non-healing diabetic or divascular ulcers, or infection, or congenital malformations. There are multiple types of surgery involved with an ankle amputation. The 3 main types of surgery or levels of amputation at the ankle, all named after their founding surgeons, are Symes, Pyrgoff, and Boyd amputations, as shown in this diagram. Disarticulation amputations can have a wide variety of prostheses prescribed, depending on the nature of the amputation and residual limb. On the left are two examples of through ankle prostheses, the first being a low-profile foot and prosthesis compared to the second image of a prosthesis with a high-energy foot to assist with running and dynamic sports. The third image is from the Atlas of Amputations and Limb Deficiencies. This highlights a medial socket design with a basic foot, and finally, the last image on the right is figure 3 from the same resource that shows the limb with a sock-on, custom foam insert, and then the final stovepipe type designed prosthesis. The next level is a transtibial or below knee amputation. This is an amputation that is through the tibia and fibula of the lower limb. Transtibial amputations may be required due to trauma, tumors, infection, or congenital deformities. Transtibial amputees also have a wider variety of options for their prosthesis, depending on their activities of daily living and ambulation goals. Transtibial amputations have a wider variety of sockets and suspension options, as well as a wide variety of componentry. In the UK, prosthetic options will be discussed with the amputee and a decision determined by the amputee's realistic goals, expectations, and requirements for day-to-day functioning, including work and leisure-based activities. Knee disarticulations are one of the less common lower limb amputations and are usually required post-trauma or as a result of tumours. However, with advancements in surgery and technology, there may be more seen within clinics. Through knee amputations do allow amputees to weight bear compared with transfemoral, and so if limb salvage is possible, this may be an alternative. Transfemoral amputations are often required for individuals who have non-reconstructible peripheral vascular disease, severe lower limb trauma, infection, or large tumours. Ambulating with a transfemoral amputation expends 65% more energy, and as such, rehabilitation required can be prolonged. Historically, a transfemoral prosthesis can be quite heavy, and some individuals may opt to ambulate with crutches or a wheelchair. However, with advances in technology, lightweight materials, and prosthetic components, there are more options that are now available. Amputations through the hip joint and the pelvis are useful surgical options for managing various generally severe pathologies of the upper thigh, buttock, and pelvis. Neoplasms, including primary bone and soft tissue sarcomas and metastatic disease, is a common indication for these high-level amputations. These lower limb amputations are less common and may not be seen in every clinic. They have a high rejection rate due to the increased energy requirements and weight of the potential prosthetic option, as well as the discomfort experienced, particularly in sitting with prosthesis. As you can see in the image on the left, in terms of the cumbersome nature of these devices. However, advances in technology are improving, and the acceptance and use of these prostheses is increasing. This is Johnny, who has a clinical support role as a clinical support technician. In his role, Johnny has face-to-face appointments with patients whose prostheses need repairs and can see up to 4 patients a day depending on the demand. He ensures the clinical environment is suitable for the patient, helps them into the clinic room, and, if necessary, helps them to don and doff their prosthesis. He discusses directly with the patient the issues they are having with their limb and carries out necessary repairs while the patient waits. Should the patient communicate that they are having a socket fit or alignment issue, Johnny will liaise with the prosthetist to arrange a prosthetic review appointment. If he becomes aware they have a skin problem or wound, he can suggest they are seen by the doctor. This role means patients do not have to wait for an appointment with their prosthetist who, for this type of repair, would bring the limb into the workshop to have the repair carried out. All of Johnny's roles as a clinical support technician help to provide a more efficient service to the patients. The field of prosthetics is vast. With the development of the support worker role and an increase in awareness and educational resources, the support worker role will continue to develop. This presentation has been designed to give an overview of the types of lower limb prostheses that support workers may be required to assist with, from manufacturing for those undertaking apprenticeships to those working in a clinical support role such as Johnny. For those wanting to pursue a support worker career in prosthetics and orthotics, More detail and education around the different devices will be provided as part of your on-the-job training. For more information or to access more learning resources, please contact BAPO at the BAPO website www.bapo.com. Main prosthetic resources used in this presentation.